Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
Good morning. Good morning. What is up? Hope you guys are doing all right. New buttons and stuff on StreamYard today, it looks like, and we got a new overlay to drop up there. Got a little tweaking to do on some of that. Hope you guys are doing all right, man. It's a beautiful Tuesday morning here in Austin, Texas. And we are going to jump on and talk about Medicare supplements today. Medigap plans, Medicare supplements, all the same thing, right? Just two words for the same product. But we're going to dive into that. I've noticed that Medicare supplements are making a bit of a resurgence, so to speak. But they're also changing quite a bit as well. So I want to talk to you guys about that. I've seen a lot of agents asking about it, saying, man, I wish I could just learn Medicare supplements. Medicare Advantage plans are peeling back in some areas. And certainly some areas are worse than others, as we've seen, right? Some states like the Dakotas, Idaho, I think Connecticut, et cetera, have really struggled with Medicare Advantage plans due to some of the commission reductions, plan exits, et cetera. So Medicare supplements are becoming a little more of a hot product. And there's a lot of agents out there that came into this business selling $0 Medicare Advantage plans that have never learned Medicare supplements, don't know anything about them, and don't know really how to ask for premium dollars. So we're going to talk about some of that. I've got some presentation material I'm going to throw up. I will give you a quick disclaimer. The presentations that I'm going to show you, they're a little bit outdated in regards to some of the Medicare numbers that you'll see on some of the slides, but the content is still the same. Medicare supplements have really not changed that much over the years. There are a few states that are making more regulations in regards to guarantee issue options, such as policy anniversaries or birthday rules. Texas has a new rule for ALS disease that offers guarantee issue. Like there's a few little new nuances in that regards. But as far as the basics of the plans, they have not changed, right? The plans have not changed at all. There are some regulatory changes, and we will certainly include some of that. So we're going to dive into it and make sure that you guys understand how Medicare supplement plans work, why someone might prefer a Medicare supplement plan over a Medicare Advantage plan or vice versa, and certainly who the best audience is for Medicare supplement plans, and certainly the benefits, et cetera, et cetera. So we will go through that. I'm going to give you some recommendations on what plans I would sell, why I would sell them, et cetera, et cetera. We're going to dive in. I do have some news that I want to run through first. And as always, this show is brought to you by DFY CRM, our CRM of choice. And unfortunately, Eric will still not let me tell you about the new updates that he has coming. I apologize. I've been talking about them for a bit. I will say they're very snazzy, and I have yet to see a CRM that is incorporating these. I saw someone ask in a Facebook group, I don't remember which Medicare group it was or insurance group it was, but they were asking about a specific feature. I still can't even say it. They were asking about a specific feature like, hey, is this feature available in a CRM? Well, it's not yet, but it will be soon. And unfortunately, I still can't tell you what it is. But stay tuned because we will have some big drops and some announcements. And once they are ready to release it, we'll definitely be doing a demo so you guys can check it out closer. But with that said, I want to dive into a wee bit of news for you guys. There's been a couple of things going on that are they're worth talking about. As always, I like to talk about fraud, number one. So right here, we have an article from CBS News that just came out yesterday. And I actually talked about this a couple of weeks ago. Actually, it was in January. It was right at a couple of weeks ago. Wasn't too long ago. But this is a Russian-run Texas medical supplier at the center of a massive Medicare billing scheme. You guys may remember a couple of weeks ago when I talked about them picking up this dude, Nika Makutadze. I'm going to Italy soon, so I kind of want to practice that in my Italian, Nico Makutadze, but that's not right. He's Russian. You have to say it like it's a record being drugged backwards. Nico Makutadze, something like that. But anyway, he was a Russian citizen living right here in Austin, and he was working with Sunshine Senior Solutions out in Delray Beach, Florida, to fraudulently bill people's Medicare numbers for catheters, urinary catheters that nobody needs. They picked him up at the end of January, and now they are realizing that it is a much larger operation than they originally thought. It says here that in a little more than a month, the company submitted claims for 78,663 items, mostly intermittent urinary catheters, billing roughly $134 million, with $90 million initially processed as paid. Medicare suspended the payments to Centurion on October 2nd, but supplemental insurers continued issuing checks. So that's one of the things that is important about the fraud. Like, not only does it affect Medicare, but for those clients or those beneficiaries that also have a Medicare supplement plan, that Medicare supplement plan is picking up their 20% of those urinary catheters too, which affects claims loss ratio, which there in turn affects rates. So cracking down on this fraud is super important. It's interesting because they go in and they talk about this, and there's employees that work for them, and they had no idea what was going on. They were in charge of basically getting mail and just scanning documents in. And they were like, hey, we just thought they were doing medical records, so just scan it in. We had no idea that they were billing Medicare fraud. So a little more development in this story. It's a lot larger than they originally thought. I will put that in there. But again, they found out that it's not just him and Sunshine Senior, but there's a second company involved that was right here in Texas linked to him. And the total is $3.34 billion. Wow. That's a lot of money. And where was that money wired to? Guess what? It was wired to Hong Kong and China. Imagine that. So there we go. A little bit of fraud going on there, as always. A little bit more. Check this one out. This one's wild. Jury convicts a former NFL player for $328 million in a Medicare fraud scheme. You don't say. Federal jury in Texas, again, here we are in Texas, convicted a former NFL player and current lab owner for orchestrating a $328 million healthcare fraud scheme involving medically unnecessary genetic testing. You may remember right around the kickoff of COVID back in 2019, 2020, that genetic testing schemes were going around big time. There were cancer screening kits, COVID testing kits, and genetic testing kits that were getting shoved out and billed to Medicare beneficiaries' numbers. Well, guess what? Keith J. Gray, I don't know what team he formerly played for. If anybody knows, feel free to drop it in the comments. But he was found guilty of conspiracy to defraud the U.S. and to pay and receive healthcare kickbacks, 5 counts of violating the anti-kickback statute, 3 counts of money laundering. Prosecutors said that Gray paid kickbacks to marketers in exchange for Medicare beneficiaries' DNA samples and personal information, and then signed physician orders authorizing the testing. Marketers allegedly used telemarketing campaigns to solicit seniors and then engaged in doctor chasing, pressuring primary care physicians to approve testing for patients who had been pre-screened by non-medical personnel. So pretty wild. I'm not going to go through all of this. It's just another statement of rampant fraud that does exist in the Medicare space. And as an agent, there's not a ton that you can do. The main thing you can do is to certainly inform your clients. Number one, Medicare will never, ever, ever call you on the phone. They will only ever communicate with you by mail. So if someone calls you, Betty, and they're trying to talk about Medicare over the phone, it's either an agent like me, hopefully a reputable one like me, or it certainly could be someone trying to fraudulently bilk your beneficiary number. So don't just willy-nilly start giving your Medicare ID out to anybody over the phone. As a matter of fact, save my phone number. Let me show you how to do some phone blocking skills to block some of these other people. And if anybody talks about Medicare and it ain't my phone number, just hang up on them, because Medicare will never call you over the phone. So it's always going to be either another agent trying to sell you something. I've already taken care of you, so you don't need them. And then anybody else that's going to be is probably a fraudster. Moving along. And this is part of why I wanted to talk about the topic today. This is in Healthcare Dive, and it shows that Medicare Advantage growth decelerates as insurers shed members for 2026. Don't take that headline too dramatically. Medicare Advantage ain't going anywhere by any stretch of the imagination. It is definitely here to stay and is still growing. It's just not growing as fast right now, right? We've seen that massive pullback. We've seen some commission reductions, basically a correction, which we were certainly due for. This article, I'm not going to go through this whole one either, but it basically talks about some of the numbers, right? 35 million people were enrolled in privatized Medicare Advantage plans. Now it's down to about 34 million people. It talks about some of the carriers that dropped members. And this was something I did not know, which I'll show you in a second. But yeah, United Healthcare is down 9%. Elevance, Centene, CVS, their MA membership dropped 14%, 4%, and 3% respectively. Right? CVS is down. Like all of these carriers are down, except Humana was one of the notable exceptions to the trends. It says Humana was the second largest payer in MA, expanded its presence in the program, and a move that could result in Humana supplanting United Healthcare as the largest MA insurer. Wow. Significant gamble, but given the forecast, they believe it will pick up. So they picked up an actual 1 million additional members, which is wild considering how many plans they made either non-commissionable or reduced commissions, and had some, they still had some serious plan exits, like some of the other carriers, but they managed to actually pick up members. Outside of them, some of your other smaller carriers like Devoted jumped quite a bit. They doubled their membership for open enrollment from about 210,000 to almost 470,000. Scan Group had significant growth. So we saw some of these smaller carriers that might be slightly more regional actually have some pretty significant growth, while the big box carriers, other than Humana, had some pullback. So I'll drop that article in the group as well. You guys can check that out. And then we have a little bit of good news. You guys may have seen this, but this was just dropped this morning. But Medicare telehealth coverage has been renewed for 2 years. The extension is one of 8 big wins that happened because the American Medical Association fought for them. And now they are pushing for permanent change. So Medicare telehealth is something they want to make permanent. I would say our current administration is fighting it because they believe that telehealth leads to fraud. And we've certainly seen an uptick in fraud, partially, I'm not going to blame it on telehealth, but the expansion of telehealth that happened during the pandemic, during the federal emergency, certainly contributed to a lot of the fraud that was out there, because everybody was quick to approve and prescribe and so forth. But this article basically talks about it and just says the basics. Again, I'm not going to go through the whole thing for you because there's really no reason to. The crux of the matter is right what the headline says, which is that Medicare telehealth coverage is renewed for another 2 years. So pretty solid. I'll get this article and you guys can jump through it and dig through some of the meat in it. But again, it just talks about some numbers here and there. The big point, again, is that telehealth is sticking around for a while, which is great for a lot of folks. That has been a question I have been asked several times from beneficiaries, like, hey, what are they going to do about telehealth? And I'm like, well, they're extending it for a little bit, but it may go away. And it looks like it would. And then now we find out it's going to be around for 2 more years. So good stuff there that you can tell your beneficiaries, especially some of your folks that live out in the more rural areas, right? That sometimes struggle to get to the doctor. So, all right, let's dive into it. So this is a presentation, and I did this presentation live for you guys once before. Like I said, it's been a few years. So some of the numbers, some of the Medicare numbers that are in here are still old, because I think this presentation was back from 23 or 24. but I will make sure those are pointed out, and you should already know them anyway. That doesn't really matter because the meat of the presentation is about Medicare supplements, what they cover, what they don't cover, why we would sell one plan over the next one, yada, 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 the important shit. And I will make sure that go over that with you guys. So just diving right in, right? This is a handbook that if you're in the Medicare space, you should 100% have a digital copy of. Anytime an insurance company finds a new policyholder for Medicare supplement, when you submit a new app, this is supposed to get mailed to them as part of their package. I don't think Medicare still mails that out, but I remember when I was in the field originally back in 04, 05, 06, selling Medicare supplement plans, we had to hand deliver this guide to everybody that we sold a policy to, along with the outlining coverage and so forth. So you had to have a trunk of materials when you were selling Medicare supplements before. Now, this one, obviously, the cover is theirs for 2023. They put out this guide every year. It is called the Choosing a Medigap Policy Guide, or the Guide to Health Insurance for people with Medicare. And it goes through every single detail that you would want to know specific to Medicare supplement plans. There is a new one for 2026. You can download it right from the CMS website. All you got to do is Google 2026 Choosing a Medigap Policy Guide, and you will find it. And similar to the Medicare and You Guide, which goes through all the nuts and bolts of Medicare, this is the same thing, but specific to Medicare supplement plans. So pretty much any question that you would ever have about Medicare supplements can be answered in that little guide. It's got an appendix in the back. You can look up the topic or the question, basically, find the page it's on, and boom, bang, pow, there's your answer. So I would highly encourage you, if you are selling or thinking of selling Medicare supplement plans, get a copy of that guide, put it in your bag, or put it on your desktop as a reference tool. So we're going to go through quite a bit, right? What is a Medigap policy? How does it work? What does it cover? We're going to talk about the standardized plans that exist in most states. And I will point out some of the states that have non-standardized plans. I'm not going to go into detail on those non-standard plans. But I will point out the states at least. And then if there's some Q&A, please feel free to drop questions in the comments as I go through this. I'm happy to answer them. We will go through some plan comparisons. And more importantly, why would someone choose Plan F? Why would someone choose Plan G? Why would someone choose Plan N? What I will tell you, man, is that if you can learn Medicare supplements, they're truly the easiest product in all of Medicare to learn because they're standardized. And we'll get into more of that. I'm going to tell you about the macro legislation to make sure you understand it, and how to decipher which plans I can sell based on their Part A effective date. We'll talk a little bit about enrollment eligibility, selling to T65s versus selling replacement plans, some of the guarantee issue scenarios, and some of the underwriting basics, and understanding some of the state variations. So what is a Medigap policy? It is supplemental insurance sold by private insurance companies designed to cover the coinsurance gap in Medicare. So if you understand how original Medicare works, well, you know that it doesn't cover everything, right? It has cost gaps. It has a Part A deductible. It has a Part B deductible. It has Part B coinsurance, right? It has copays built in for skilled nursing and things. Your Medigap policy doesn't give you additional benefits. It's only going to help you cover the deductibles, the copayments, and the coinsurance that exist in Medicare. So if we think of Medicare generally as an 80-20 plan, which it not perfectly, but pretty much almost is, this is designed to help you cover that 20% coinsurance, right? And I always like to put this in when I'm speaking to a beneficiary to help them understand, because sometimes they might think, well, 20% doesn't sound like a lot. For some people, they may get, oh yeah, 20% could be a lot of money. For some folks are like, well, 20% is not that big a deal. What's 20%? So I always want to make sure they understand it in real world terms, because what everybody super needs to understand is that the 20% coinsurance that exists in Medicare doesn't have a cap. It doesn't have a maximum out of pocket like Medicare Advantage plans do. So your 20% coinsurance could be as high as necessary to cover the bill. So what does that look like in real world terms? Well, 20% of a doctor visit is probably about $50. The average doctor visit nowadays is right around $250. Medicare is going to cover 80%. You're on the hook for $50. You're on the hook technically for 20%, which is going to be about $50 plus or minus. Depends on how extensive that doctor visit is, right? If it's a big doctor visit where you're getting all kinds of labs and x-rays and blood work and stuff done, yeah, it's going to be a little higher. But if it's their basic annual check-in, little checkup, right, $250, you're going to pay about $50. 3-day stay in the hospital, you can look it up in your state. But in Texas, I can tell you that the average hospital expense or the average hospital stay is 3 days. And that average cost is about $15,000 all in, which means 20%. That's about $3,000 coinsurance for you as the beneficiary. That including your Part A deductible. You get into something more like a chronic illness, massive surgery, heart attack, stroke. Now we're looking at 5 to 6 figures in expenses. So you can see pretty quickly that it adds up very fast. Just look up some of the costs for some of these different diseases, treatments, surgeries, etc., and you'll get a really good idea of what 20% looks like. Now, how does it work? Well, as you remember, if you do remember and you understand Medicare, I'm kind of running this presentation with the guys that you understand Medicare, the original Medicare card, the red, white, and blue card, then you know that with that red, white, and blue card, you get nationwide coverage. You can see pretty much any doctor, coast to coast in all 50 states and Puerto Rico. 99% of providers all accept that red, white, and blue card. The 1% of providers that generally don't are usually in the behavioral health category. Psychiatrist, psychologist, neurologist, all in that space, which isn't really that uncommon because psychologists and psychiatrists generally don't accept much insurance anyway, right? So a lot of that is cash out of pocket. I will say that Medicare has gone through the work of expanding mental health reimbursements. So some people that need some mental therapy, whether it's marriage counseling, etc., some of that can now be covered by Medicare. So we are seeing a very minor uptick in those mental health folks starting to accept Medicare. But for the most part, it's still about 99% of providers, maybe slightly higher, that accept Medicare, right? And that means that you can see any doctor in all 50 states that accepts Medicare. You don't need referrals. You don't need anybody's permission. All you have to do is call and say, hey, do you accept Medicare? Yes, cool. Are you accepting new patients? Yes, cool. When can I come in? That's it. So it works like an 80-20 plan. After the deductibles are met, Medicare pays 80, you pay 20 as the coinsurance, or your Medigap policy can pay that for you, right? As I kind of already went over in that previous slide, right? So the cool part about it is that your Medigap policy is portable. It will travel wherever your Medicare card goes. And it doesn't matter which Medicare supplement carrier you have. Doesn't matter if it's Aetna, Blue Cross, Humana, or Polish Falcons of America. It does not matter. They are all standardized. If the doctor accepts Medicare, if the provider accepts Medicare, he accepts all Medicare supplement plans, every single one of them. So this is something that you have to train your clients, because your clients are going to ask the question the wrong way. They're going to call the doctor and say, hey, do you accept Polish Falcons of America? And he's going to be, I don't even know who the hell they are. Hell no, I don't accept them. That's the wrong question to ask. They should just be asking, hey, do you accept Medicare? And if he says yes, then he accepts all Medicare supplement plans. It doesn't matter who it is, because the doctor ultimately will not bill the Medicare supplement plan. The doctor is simply going to bill Medicare. Medicare is going to pay their 80%, and they're going to electronically cross over the amount to the Medicare supplement carrier, who will then reimburse the rest of the amount. It's super streamlined. It's super fast. I have sold thousands of Medicare supplement plans in my entire career, and I can tell you I have only, that I can think of, maybe 3 times that I've ever had to get wrapped up in any kind of help with the claim. I know it happens from time to time. Some people maybe have better luck or worse than others in regards to dealing with that. But it is such an automated, streamlined process, especially nowadays, as with the advances in electronic billing and so forth. It's very rare that you would have to help someone deal with the claim issue. It does come up from time to time. I had one just the other week that popped up, and it wasn't even a claim issue. It was just one of the people that was in the office didn't understand what she had, wasn't really the billing person, and was demanding more money from my client. And all I had to do was get the billing person on the phone, educate her, let her know, no. She doesn't owe you any money. Stop trying to hit my client for money. She doesn't owe you anything. And then she's like, oh, okay, I got it. Piece of cake, right? But it's fairly simple. Your out-of-pocket for your client is going to depend on which specific Medicare supplement plan they pick, which we will get into. So what does it cover? Well, it's going to cover exactly what Medicare covers: inpatient and outpatient services that are medically necessary. It doesn't cover any dental, vision, or hearing. It doesn't automatically include a bunch of chiropractic coverage or cosmetic coverage. It doesn't cover your prescription drugs. It just covers Part A and Part B benefits. And it's just the cost gap that Medicare's not picking up, right? So instead of leaving your client on the hook for a cost gap with no max out of pocket, you use a Medicare supplement to plug that hole, and they know exactly what they're spending on healthcare every single month. It's super easy for them to budget. So like I said, Medigap is no different. It's only going to pay Medicare approved claims. If Medicare pays, then Medigap pays. A few key points. Number one, it's portable. I mentioned that already. So wherever your Medicare card is accepted, all Medicare supplements are accepted. Doesn't matter who the carrier is. They are all standardized. It is guaranteed renewable by CMS. What does that mean? That means that the only person that can cancel their Medicare supplement policy is the policy holder themselves. And they usually have to cancel it in writing or by stopping their premium payment. They can just stop paying the premium on it every month, and it will cancel automatically after a 30-day lapse period, right? Otherwise, a few carriers will allow them to call in and cancel it, but in most cases, they have to write a letter, fax it in, email it in, whatever, and they can cancel it. But a lot of times you'll see them, one of the easiest ways to cancel is just change the billing mode to direct bill. Don't pay the bill. It cancels itself. That's another thing you can do. So again, it can only be canceled by the policyholder. You as the agent cannot cancel it. The insurance company cannot cancel them, right? The only person that can cancel is the policyholder by non-payment of premium. So therefore, if they pay their premium every month, it is guaranteed renewable. That further means that in the event the insurance company makes some bad bets and becomes insolvent because they make some bad investments, right? That CMS will step in, or the state DOI will step in that case and put that company in receivership, manage the claims, manage the business, make sure every claim gets paid, etc. I've only seen this happen once in my career. It happened back in 2008 with the housing market crash. Shenandoah Life, a carrier out in the East Coast, they had they invested all of their premium dollars, or at least a large chunk of them, if not all of them, into Fannie Mae and Freddie Mac home loans. And as we know, that whole housing market crashed, which means they lost all of their money. They became insolvent. The state had to step in, put them in receivership. The state was able to administer the product. They paid every claim. They even paid all the commissions to the agents that sold that business and brought that company back out. And I think they have an A rating again. So it is guaranteed renewal by CMS. Even if the insurance company becomes insolvent, you will still have your insurance and still be covered. So again, it can only be canceled by the policyholder. They also cannot be singled out for a rate increase, right? It's unlike car insurance in that regard. So if you have car insurance and you get in a wreck, even if it's not your fault, your rate's going up. Not true with Medicare supplement plans. Just because you get sick as the policyholder and have a bunch of claims, they can't single you out for that rate increase. The rate is built on the whole health of the whole book. So if you have 5,000 people on that group, on that Plan F block of business, or on that Plan G or that Plan N, right, they're going to spread that risk across all the members and adjust rates as necessary based on their claims loss ratio there. Super important to understand is that all Medigap plans and their benefits are standardized. This means that if you know, for example, that your client wants a Plan F, as in Frank, or a Plan G, that it doesn't matter which carrier you buy that plan from, the benefits are identical. The function of the plan is identical because they're standardized by the federal government. It is illegal or against the rules of the game for any Medicare supplement plan or carrier to offer more benefits on their plan than the other company's plan. So a plan G is a plan G is a plan G. It doesn't matter who you buy it from, which means price is the only real difference between one plan and the next. And that is actually stated in the Medicare Supplement Guide. This is straight from Medicare. All Medigap policies must follow federal and state laws designed to protect you, and policies must be clearly identified as Medicare Supplement insurance. Medigap policies are standardized, and in most states are named by letters plans A through N. Each standardized Medigap policy under the same plan letter must offer the same basic benefits no matter which company sells it. Cost is usually the only difference between Medigap policies with the same plan letter sold by different insurance companies. So it makes almost no sense to buy the brand product that's $40 more per month when you can buy a Medicare supplement that's way cheaper, even if you don't recognize the carrier name. Now, that doesn't mean that you as the agent should go find every cheapest Medicare supplement plan and get contracted with them. There are some nuances in that, and I will go through some of that in Medigap 201 if we have time to get all the way through it, on how you as the agent need to be thinking and picking the specific carriers that you want to sell, right? Because there are, unfortunately, insurance companies that will come out with a super duper duper low rate trying to buy a business, and then they really don't have the financials or the skill set to maintain it, and then rates do shoot up, right? And so you want to pick carriers that, number one, are super affordable, but also they've got some experience in the business, they've developed a good product, they've got good financials, and they can maintain the business for the most part. And I know in some cases I'm saying that, and everybody's like, well, shit, everybody's taking high increases right now. And for a big part, you're true. That are very true. We've had Medicare supplements have had a rough go of it in the last 3 years, for sure. I know in some cases they're blaming that on the pandemic, saying that there was a whole bunch of voluntary services or treatments surgeries that people weren't getting done because they didn't want to go into the hospital during COVID and get sick. So all of that was suppressed, and then there was a flood. So we saw an unusual amount of utilization after the fact when the federal pandemic was kind of released, and they weren't expecting that, and that flood of claims came in and it required them to shoot up rates. Probably very true. I think the fraud has a big part of it. I mean, if you guys have been following me, I've been pointing out billions and billions of dollars in fraud. The one I just talked about today was over $3 billion. There's a couple out in Scottsdale, $1 billion. Like, there's a ton of fraud. So you know that not only does that affect Medicare, again, that affects Medicare supplements. So I think that's part of why we've seen higher than normal rate trends. But again, standardized plans. So in most states, you're going to see plans A, B, C, D, F, G, K, L, M, and N. The two plans F and G with an asterisk, they have high deductible options offered in some states, where instead of the basic plan G, you can get a high deductible plan G, where I think the first like $2,400 or something is on you before the plan kicks in. Massachusetts, Minnesota, and Wisconsin offer non-standardized plans. They have the same benefits, but instead of it all being pre-built into a plan that you can just pick, you go and you pick and choose the benefits, kind of like almost like a cafeteria plan, where you kind of go through the line. You're like, I want some of that. I want some of that. I want some of that. And you build your plan G, or you build your plan F, or your plan N. And as you build it, the price comes up. Now, one thing that's super important, if you're in all these standardized states, you do not have to memorize all the different plan options. If I were you, I would only memorize plan F, G, and N, which are super easy to learn, because those are the three most common plans that are sold. Almost nobody buys plans A, B, C, D, certainly K, L, and M. I don't think anybody even sells plan M, as in Mary. You'll be hard pressed, depending on the state that you live in, to even see plan B or D on the charts. So every state's going to be a little different, because in addition to Medicare creating the plans, they give them to the states, and every state Department of Insurance has their own regulations on how these plans are presented. I'll say it that way. For example, in Texas, if you're an insurance company and you want to offer Medicare supplement plans in Texas, you're only required to offer plans A, F, and G. That's it. You can choose to offer more if you want. And most insurance companies, they're not going to take on more risk if they don't have to. They're going to follow the state laws. So a lot of insurance companies, they're only going to offer plans A, F, and G in Texas. However, they will all also offer Plan N because they've come to realize that Plan N is the fastest growing Medicare supplement plan being sold today. So in Texas, pretty much every Medicare supplement carrier you find is only going to give you A, F, G, and N. In other states like Ohio, they're required to offer more plans. So I think in Ohio, they have to offer A, B, C, D, F, G, and N as an example. Maybe even they have to offer all of them. So state regulations will be a little bit different. In some states, you'll have access to more plan options than others, but that doesn't mean you should be selling those plans. There are some specific reasons why you probably should sell a plan A or a plan B. If you have a plan C still available in some areas, not a terrible option. You just want to understand the regulation on when you're allowed to sell plan C, etc. High deductible options. I sold a bunch of high deductible plan Fs a long time ago when I was in Houston to a bunch of rich guys that could easily afford the fat deductible before their plan crept in. And you get a super, super low rate. Like high deductible plans are very inexpensive. Commissions on them aren't that great, let's be honest. But I will say the retention on them is generally really good. As long as that beneficiary is cool with the fat deductible, those plans work great. But more importantly, the three that you really want to learn is F, G, and N. Now, if you look at the Choosing a Medigap policy guide, you're going to see a chart that looks like that. And it will show you all the different benefits. So, for example, on the left are your benefits. They call them benefits. The real way you should look at those are the coinsurance gaps that exist in Medicare. The Part A deductible, the Part B deductible, the Part A coinsurance, Part B coinsurance, skilled nursing coinsurance, excess charges, foreign travel, right? And then it shows you through the chart how much the different Medicare supplement plans cover of that gap. So if you look in the center under Plan F, you'll see that almost every box is filled 100%. The only one that's not is at the bottom, foreign travel emergency. So a Plan F covers 100% of the 20% coinsurance gap. In other words, that is real first dollar coverage. If your client or your beneficiary is enrolled in a Plan F, when they go to the doctor or they go to the hospital, they pay $0. Nothing. No deductible, no issues, no copayments, no coinsurance, 100% coverage. And again, that's based on medically necessary hospital and doctor visits, right? They don't get all of a sudden new benefits, just to reiterate that. Plan G is almost the same, but there's one difference. You'll see that the Part B deductible is not covered. So under Plan G, they have to cover the Part B deductible first, $283, and then after that, they'd be covered 100%, right? So you can use this chart to help you learn the plans, but I'm telling you that you only need to learn Plan F, G, and N to memory. Once you have those committed, very rare are you even going to sell any of the other plans. And again, that's going to be a little bit state dependent, but you can use these charts to help you. So that's what the chart looks like in the Medicare, the Choosing a Medigap policy guide. A carrier, if you get a cotton, now this is unusual because most carriers don't even send this shit out anymore. This is old school stuff. But when the carrier would send their big rate guide out, they had this chart on the front. Same concept, but instead of showing 100% in each box, they just put a check mark that it's covered, right? And any carrier that sells Medicare supplement plans in their outline of coverage and rate guide, they are required to list this chart, and they have to show all plans on the chart. But they're going to gray or highlight the plans that they sell, right? So if you're looking at this, and I think I got this from Mutual Omaha as an example, this is their required chart of all the plans, A, B, A through N. But then you'll see that A, G, N, and F are all grayed out or highlighted. Those are the plans that they actually offer in that state. So MACRA is super important, and I want to make sure you guys have a handle on this, especially for some of you new guys that came in after the fact. If you've been here for a minute, you probably remember the MACRA change and you know what it is. But if you're brand new, you had no idea what's going on and why it works. MACRA is the Medicare Access and Chip Reauthorization Act. What it basically did as far as Medicare supplement plans are concerned is that it split all Medicare beneficiaries into two pools. You have now Medicare beneficiaries that aged in to Part A, as an Apple, your hospital coverage, before January 1 of 2020, right? So their Part A date, effective date, or actually eligibility date, not even effective date, their Part A eligibility date was prior to January 1, 2020. That's one group of beneficiaries. The second group of beneficiaries is everybody that aged in after January 1 of 2020. Okay? So really all it did, from just simplified as best I can, is split it into two groups of beneficiaries. The group before 2020 and the group who get Part A after 2020. The group that have Part A before 2020, nothing changed for them. They have access to all plans, no problems, they're good. Everybody that aged into Part A after 2020 can no longer purchase Plan C as in Charlie or F as in Frank, period. And that includes high deductible Plan F as well. They can get high deductible Plan G. That is the primary rule that it changed. Now, it also changed some of the guarantee issue rules. So when someone gets guarantee issue for Medicare supplement due to loss of coverage, right? They lose their employer group plan. They get booted off a Medicare Advantage plan and a plan exit. They get guarantee issue options. Now, generally, and again, this rule varies a little bit by state, so you'll want to check your specific state guidelines on what are the choice guarantee issue plans that you're allowed to sell when you're in a straight guarantee issue option. I'm not talking about open enrollment options when someone's brand new to Medicare. I'll get to that in a second. But I want to hit on this real quick since I'm covering MACRA, right? That there are some specifics when you're running into a straight guarantee issue situation due to loss of coverage, where they get their special election period for 63 days. They're limited on their plan selection if you're going to go guarantee issue. For all the people that are prior to 2020, they can buy plans A, C, or F, guarantee issue. In some states, that's going to be a little different. I think Ohio has, like, they can get A, B, C, D, and it's something like that. So check your specific state, and it's listed in that CHAMP guide that I showed you at the beginning of the thing. Choosing a Medigap policy, we'll go over that with you. A good underwriting guide from a Medicare supplement carrier, one of the best ones out there is Mutual of Omaha's. Even if you don't like to sell Mutual Omaha, get a copy of their underwriting guide for Medicare supplements. It's one of the best ones out there because it will go through state regulations and variations and tell you, hey, if you're in Georgia, right, these are the plans you're allowed to sell for guarantee issue based on these parameters, right? It'll tell you which states have under 65 rates and which don't, because not every state is required to sell Medicare supplements to people under 65. It'll tell you if you have to ask the smoking question when they're in open enrollment or a guarantee issue, even though you don't have to ask the health questions. So you still have to charge them tobacco rates because that varies by state as well. So it'll go through some of that with you. Now, for people that were aged into Medicare after 2020, again, standing on the state, their plan choices are A as in apple, D as in dog, or G as in giraffe. Those are their guarantee issue options for the most part. Plan N as in Nancy is never on the table for guarantee issue other than open enrollment. So why would someone buy Plan F, right? This is the outline of coverage. Again, don't pay attention to the numbers that are in there from Medicare. Like I said, some of these slides are old. It's the concept that you need to pay attention to, right? Medicare, it shows you what the service is, what Medicare pays, what the plan pays, what you pay. It's pretty simple. Just look at the far right column of what you pay. Plan F shows that you pay 0. The only time you would pay anything is if you go beyond your additional 365 days of hospital coverage, or if you go beyond 101 days of skilled nursing coverage. Other than that, you pay $0. So why would someone buy Plan F? Well, because they don't want to have a claim at all. They don't want to pay anything. They just want to go to the doctor, go to the hospital. Super simple. First dollar coverage. That's why they want it, right? So whether they're hospitalized, whether they are going to the doctor, doesn't matter. Therapy, skilled nursing, at least in those first 100 days, they pay nothing, zero, right? And that's just the outline of coverage that shows you that. Other reasons why they want. Number one, if their Part A was eligible prior to January 1, 2020, I just showed you the macro rules, right? So I had a gentleman that was in my office the other day that needed help. He wanted Plan F. His Part A eligibility date was before January 1, 2020. I was able to still enroll him in Plan F. One of the common misconceptions on this is that those people also have to be in a Plan F right now in order for you to rewrite them a new Plan F. That is not true. They can have a Medicare Advantage plan. They could have no Medicare Supplement. They could have any plan they want. But if their eligibility date for Part A was prior to 1/1/2020, you can always sell them a Plan F for the rest of their life, assuming that they're healthy enough to qualify, unless they have a weird guarantee issue option. So they're going to get first dollar coverage, no payments, right? They just pay the premium. They pay nothing else. Another reason why Plan F might be a solid plan to write right now for the folks that qualify for it and they're healthy enough to get through underwriting is that most of the Plan F blocks are going to be underwritten to a large extent. The exception will be this last AEP, where we saw some larger than normal plan exits. A lot of those folks that were aged into Medicare prior to 2020 and just lost their Medicare Advantage plan, if they decided to go guarantee issue back to a Medicare supplement using the macro rules, they would have gone back to a Plan F. So we are going to see a little bump in guarantee issue people getting placed on Plan F this last year and this year. But for the most part, anybody buying Plan F today is probably having to go through underwriting on it, which means if they can get through underwriting, the block of business should be healthier, which means it should have steadier rates. And then, just like I said, other reasons why someone might choose a Plan F right now is by force, because it's the only option they can get in their guarantee issue regulations through loss of coverage. Why Plan G? Pretty similar concept, right? This is, again, the outline of coverage specific to Plan G. Again, this is your hospital portion, Part A that I'm showing you, and you'll see that you pay $0, again, other than your all costs, so for hospital and skilled nursing. So your Part A coverage on Plan G is identical to Plan F. You pay nothing if you're hospitalized from day one. No deductible, no problems. Your medical services, on the other hand, you have to pay the Part B deductible, which this year is $283. So if someone's on a Plan G, when they go to the doctor or when they use outpatient services of any sort, right, in and out, I'm not spending the night in the hospital, and that includes emergency room, therapy, right, et cetera, whatever it might be, whatever their outpatient service is, that's covered under Part B, and they would have to pay $283 as a deductible. In most cases, that deductible is going to be paid piecemeal, probably $40, $50, $60 at a time. Most people are going to need to go to the doctor 3 or 4 times before they ever even hit their deductible, right? If they meet their deductible in a full year, Plan G covers them 100%. They don't pay anything else for any doctor, any specialist, no issues. So why would someone buy Plan G? Well, it's cheaper than Plan F. And depending on the state and the carriers that you might be quoting, it could be as much as 20% cheaper than Plan F, which is massive. And here's the thing to think about. And this was a more common thought process that you would have to battle with back when you could sell Plan F willy-nilly to anybody. Now you're kind of limited. But to give you an example, because you're going to use this same thought process to help you with Plan N as well. But let me just hear me out. If my annual premium cost on Plan F, let's just say, is $1,500. In Plan F, I have zero out of pocket when I use my plan. I just have to pay my $1,500 premium a year. And my only difference in benefit between Plan F and Plan G is the $283 deductible, right? A $283 benefit, which is an annual cost benefit. But my premium for Plan G is only $1,100. Well, 1,100 plus 283 is 1,383, which is less than 1,500. So from a mathematical perspective, Plan G is a smarter choice. Now, some people will still choose the Plan F because they want the ease that I don't want to have to pay a I'm happy to pay more in premium to not have any co-insurance or any co-payments, right? I found that when I was selling full-time, and it was always a battle between Plan F and G back then. It's not as much a battle now, but when it was that females tended to prefer Plan F because it was an easy plan. All they got to do is go to the doctor. They don't have to cut any checks. They don't have to pay any bills. Males, when I would show them that math, they'd be like, oh, well, the math is logical. I should choose the lower total out-of-pocket expense, even if I have to pay my deductible. So that is what it is back then. Some of that same thought process and math will go to Plan N, which I'm going to show you in a second. So again, it's a lower premium than Plan F. Look at it from the annual cost because the Part B deductible is the only additional cost that they have. So a lot of times that premium savings over Plan F will outweigh the cost of the Part B deductible. Also, and this is definitely true in the past. I don't know exactly how much water this holds now, but I think it's probably still pretty accurate. Historically, Plan G has lower rate trends than Plan F. What am I talking about on rate trends? Well, a couple of things. Now, in Texas and most states, all Medicare supplement plans are called they're rated on an attained age system, which means that every year you get older, your rate goes up a few bucks. Usually 1.5%, maybe 2% at most, right? But also, insurance companies can and usually do take a rate adjustment, I'd say about every 12 to 18 months. And they do that to fight their claims loss ratio as well as medical inflation, right? When they first rolled out the book of business, they didn't have any claims. Now, after scooping up a bunch of members, now they're starting to have claims. So they have to try to manage their claims loss ratio. How much money are they earning versus how much money are they spending in claims versus how much money that it takes to run that organization, right? Also known as the MLR or medical loss ratio. Many years ago, the Affordable Care Act said that plans had to maintain a 85% MLR, medical loss ratio. That did not apply to Medicare supplement plans, right? They do not have to maintain an 85% MLR. But if you know what the carrier's MLR is, it's super important because that'll help you understanding what the rate trends might look like at a later time. So generally, because Plan F carries higher claims, because it's zero or it's first dollar coverage, there's zero coinsurance copayments built into it, it generally has a higher rate trend to fight that MLR, right? Another reason why someone might choose Plan G is because they have frequent doctor visits. And this is actually a reason why they would probably choose Plan G over Plan N, is because they want to cap their out-of-pocket cost. And then certainly some guarantee issue regulations may affect that. So why would someone choose Plan N? Again, we're looking at the Part A outline of coverage. It's still identical to Plan F and G. There's no difference. I'm still basically 100% covered for hospitalization if I choose Plan N. The only things I'm not covered for are the same things I'm not covered for under F and G, which is if I go over my additional 365 days of hospital coverage or I go over my 101 days of skilled nursing. Other than that, if I have a Plan N Medicare supplement and I go to the hospital for 3 days, I pay $0 for the hospital side of things. I will have medical costs, just like I would with the other plans, but my hospital coverage is zero cost to me. Now, my Part B expenses are going to be a little different. They're going to be real similar to Plan G. I still got to pay the Part B deductible, which is $283 this year. That's still going to be paid in piecemeal most of the time, depending on the size of that doctor visit. So 40, 50 bucks at a time as I visit the doctor. And then if I meet my deductible, now remember on Plan G, if you meet your deductible in a year, and you have more doctor visits, you pay $0 for those doctor visits. Under Plan N, if I meet my deductible in a year for doctor visits and I have additional doctor visits in the same calendar year, this is the important part. It's a calendar year. It's not a 12-month cycle. It's calendar year. So if I meet my deductible in that calendar year and I have more visits, those doctor visits will be a maximum $20 copay. Some of them, depending on how that doctor bills and what billing codes he uses, you might have zero copay for that doctor visit. It might be $9, but the maximum it will be is $20, period. It also has a $50 emergency room copayment, but that copayment would be waived if you're admitted to the hospital in the same visit. So to help you understand that, right? Let's say you, as a beneficiary, and this is how I explain it to them. Let's say you cut your hand really bad, like slice your hand open somehow, really bad, you need stitches. You go to the emergency room, they stitch you up, send you home same day. That's $50 under Plan N. However, let's say you have some really bad chest pains and you're praying it's just bad gas, and you go to the emergency room and they're like, hey, Fred, we're going to keep you overnight. Now that claim is being billed under Part A, not Part B. And because Plan N covers hospitalization or Part A benefits at 100% coverage, that ER visit copayment would be waived. There is one other difference, and that is in excess charges. Not listed on this one here, but Plan N does not cover excess charges. What is excess charges? Real quick, right? And it says right here, actually, 97% of doctors accept Medicare assignment. So again, you have there's two metrics that doctors are measured by when it comes to Medicare acceptance. The first one is, do they even accept Medicare, which I've already told you is 99% of providers in all 50 states, plus Puerto Rico. Now, of those 99% of doctors, 97% of them all accept Medicare assignment. In other words, they all accept Medicare's public fee-for-service payment schedule for any given service that is medically necessary. They abide exactly by what Medicare will reimburse that they believe is usual and customary for any given service that you might have, right? So if Medicare says, hey, the most we'll reimburse you for a stitched hand is $1,000, then they'll get $1,000, and they abide by that, right? However, 3% of the doctors say, nah, we don't want to accept assignment. So Medicare allows them to charge something called excess charges. Those 3% of doctors, they can charge maximum 15% over Medicare's fee schedule. So if stitching up a nasty cut on your hand, if Medicare said it's only $1,000, these guys could charge $1,150, 15% more. They could charge an extra $150. Now, if you have a Plan F or you have a Plan G, those excess charges are covered. If you have a Plan N, your beneficiary would have to cover the excess charges. But if you're good at math, you already see that 97% of all doctors, providers, accept assignment. So I only have about a 3% chance that I would even visit a doctor that charges excess charges. Since Plan N came out, it's been my number one plan that I've sold. I still sell some Plan G here and there. I just sold a Plan F the other day, but I constantly advocate and push my beneficiaries to Plan N, which I'll explain more why in a second. But I have never, ever had a client call me and ask me about excess charges because they were billed some. Now, some of those clients may very well have gotten excess charges and they just didn't bother with it. And they're like, cool, let's pay it and move on with my life. And they just didn't bother to tell me about it. I would think that would be odd. I would think they would have called me and said, hey, what are these excess charges I'm being billed for? Because they probably had forgotten I even told them about it in the first place. Because let's be honest, I tell them that the deductible is $283, and then when they have to go pay it, they forget. But I have never, ever, ever, not once, not a single time, have I ever had a policyholder complain to me or ask me about why am I being billed excess charges. So I'm of the opinion that, yes, inform your clients that it's a possibility, but inform them properly and don't put them in a fear space. It's like, no, you can't buy Plan N because it has excess charges and, that won't work. So you have to get Plan G. or even better, you have to get Plan F. Don't be that agent. Learn the real math, learn the real situation, and sell them Plan N without fear, because the odds that they will ever face excess charges is extremely remote. And in some states, I think, again, Ohio is one of them, they don't even allow you to charge excess charges. So if you live in one of those states, it's not even an issue. Know your rules of your states, know what's going on. And if you know you're in a state that doesn't even allow excess charges, then boom, bang, pow. You should be writing the shit out of Plan N. Because again, you still get 100% Part A coverage. You have very minimal Part B copayments. You got to pay the Part B deductible. After that, you got to pay $20, maximum $20 for every doctor visit. So who wants Plan N? Well, generally the people that have infrequent doctor visits. How many? If you have less than 8 doctor visits in a year, I would generally advocate for Plan N, because all you got to do is the math. How much is my annual premium plus my Part B deductible? And let's throw in a couple of extra $20 doctor visit copayments, maybe 4, and then compare that to buying Plan G, where your copayments are capped because all you got to do is meet the deductible. Plan N is still going to be cheaper. And not only is it cheaper today, but Plan N has the lowest rate trends of all Medicare supplement plans in the industry. Generally, Plan F has had the highest, still does. Plan F rate trends, I think, currently are running as high as 15%. Maybe even higher, because I've seen some 30s. I think I even saw like a 40 or 50 come out not too long ago. Plan G generally tends to be high as well, usually about 8 to 12%, but I think they're even running slightly higher. Plan N with most carriers, or if we look at the industry as a law, like you can anecdotally give me some shit ass carrier that probably jacked rates on Plan N because their claims loss ratio got way upside down. But don't be anecdotal, be real. Look at the whole market as an average. The market average on Plan N is usually sub 5%. And many carriers, 0, 1, 2, 3% rate trends on their Plan N. So not only is it cheaper for my beneficiary today, it's going to be cheaper many, many, many years down the road. And yes, and Nesta, I will be talking about that. Y'all can vote in the chat. Go overtime or pick this up on a second training next week. I'm going to keep going until y'all tell me. But we're going to go over a little bit. So eligibility, who gets to buy a Medicare supplement plan? You have to have Part A and B. Pretty simple. Now, you can get it in their open enrollment period. That is the first 6 months of having Part B and being 65 at the same time, or at least 65. Because you'll get some people that don't enroll in Part B until they're 68, 69, 70. Because they've been delaying it because they've been getting good group insurance. And then they finally move over to full Medicare. But anytime that they are at least 65 years old and they have Part B, wherever that intersection of that date is, they get 6 months. They can choose any Medicare supplement plan they want that's available by carrier in the state. And they get no health questions. It is open enrollment. Do not confuse this with guarantee issue. Yes, the result is the same. But Medicare supplements do not view those terms the same. Open enrollment is when you're brand new to Medicare. And yes, you get to bypass all the health questions. In a lot of states, you can be a smoker and still get non-smoker rates during that time. And you as the agent get full commission. But guarantee issue in a Medicare supplement carrier's mindset is guarantee issue due to loss of coverage. They lost their Medicare Advantage plan. They lost involuntarily their group insurance. And I'm bypassing the health questions using that guarantee issue loophole. That is a reduced commission for you. And again, it varies by carrier, varies by state. Colorado, if I remember correctly, is one of the states that's not allowed to reduce commissions on those reasons. I might be wrong. I think South Carolina might be one too. But in Texas, they can certainly reduce comp for guarantee issue due to loss of coverage. And you usually get like $25. Woohoo, one-time comp. So don't go chase that business. Otherwise, they can get a Medicare supplement plan 365 days a year by passing underwriting. It is not subject to the Medicare enrollment periods that we're used to with Medicare Advantage plans. If someone has a Medicare supplement plan today and they don't like the premium anymore, you can rewrite them for a new Medicare supplement plan anytime you want, 365 days a year. The only caveat is they're going to have to get through the underwriting on there. That's it. So I've kind of explained this already, so I'm going to skip through a little bit of this, right? Open enrollment is your first 6 months of having Part B or turning 65 with Part B. Pick any plan you want, no underwriting. They cannot be denied. No pre-existing conditions, no waiting periods. It is immediate coverage. Anytime outside of open enrollment, again, 365 days a year, they can go through underwriting. Medicare supplement underwriting is a lot like final expense underwriting or any other simplified issue product. It's just a bunch of yes or no health questions. They don't have to go get a physical. They don't have to pee in a cup. They don't need an attending physician statement. They just answer the health questions on the app. And in most cases, the carrier is going to do one thing, and they're going to go pull their drug report from Milliman and verify that they're answering those questions correctly and that they're not taking prescriptions that would identify declinable conditions. Some carriers might do a phone interview to verify that you're doing your job is really what they're doing on those, and to make sure that you actually took time to answer the health questions. Some carriers, and I've seen this in the past, I've seen some carriers where a phone interview is required for every application. I don't think they are. I don't think anybody's doing that anymore, but there might be somebody. Most of them are doing them randomly to spot check. And certainly if you're trying to get through underwriting, you could be denied. Now, underwriting is very carrier specific, right? You'll want to look at the declinable drug list, the declinable condition list to help you learn the carriers. Or if you have access to agent toolkits, it'll underwrite Medicare supplements for you as well as final expense and other products. But generally speaking, they're looking for major conditions in the last 2 to 5 years. Confinement in the hospital, confinement to a walker or wheelchair, confinement to your bed. If you're taking oxygen, right, you're driving around an oxygen tank like it's a golf bag, that's going to be a problem. Insulin isn't necessarily a problem. That's going to be very carrier dependent. Some carriers, they will take no insulin whatsoever. Other carriers will take insulin, but depends on how many units they're taking. Pacemakers are a problem. Cancer, heart, stroke is a problem. Some of that, like cancer, some carriers might ask if you've ever had internal cancer in your life, and that would be a declinable one. Others might say, hey, in the last 5 years, have you been diagnosed or free from cancer, or 10 years, right? So they have a little bit of a look back period. Heart and stroke problems are usually 2 to 5 year look backs, depending on, again, the carrier. Heavy narcotics, they're on heavy pain meds because of rheumatoid arthritis or other problems, that's going to be an issue. Pretty much all of your nervous disorders, ALS disease, myasthenia gravis, Parkinson's, Alzheimer's, those are all out. And if you're currently in a hospital, of course, or if you're currently in rehabilitation. For example, let's say you had a knee surgery and you're in rehab or therapy to work on your knee and get better at it. You wouldn't be able to get the supplement while you're in rehab, but once you're out, assuming you don't have any other declinable conditions, not a big deal. You can get issued. So again, guarantee issue is not the same as open enrollment. Guarantee issue is due to involuntary loss of coverage. You lost coverage by no fault of your own. You're going to get a 63-day guarantee issue right. Some states will allow voluntary termination of your group plan. You'll need to look that up in the Choosing a Medigap Policy Guide to find out if your state allows for voluntary termination of group plan to get guarantee issue, or if it's only involuntary, right? Moving from one state to another or one county to another does not create a guarantee issue right for Medicare supplement. The Medicare Advantage people get that one confused, because if you're in a Medicare Advantage plan and you're right here in Travis County where I live, and you move to Williamson County, right, a different county in Texas, if your Medicare Advantage plan does not cover both counties, they boot you off of it, and you get a guarantee issue option. You get a guarantee issue option in that situation to go to Medicare Supplement, or you got to find another Medicare Advantage plan, right? But if I move from Florida to Texas, or Texas to Florida, or New York to California, whatever it matters, I don't get some weird guarantee issue right to change my MedSup. Why? Why, you ask? Well, again, Medicare's national. Medicare's a national health insurance program, and my Medicare Supplement plan is portable. So I can live in New York, get service in California on my Medicare Supplement plan. I can move from New York to California, and I don't have to change anything, period. And I can keep that Medicare Supplement plan, move to California, and still get continuous service. I just got to keep paying my rate. And then again, the thing about guarantee issue is you'll also want to check what plans you're allowed to issue, guarantee issue based on their Part A eligibility date because of that 2020 change, right? So if they were before the macro legislation where they aged in prior to 2020, most states it's A, B, C, and F. If they're after that fact, if they aged into Part A after 2020, A, B, D, and G. Now, state variations, Connecticut, Massachusetts, Maine, and New York are all guarantee issue states, meaning that it's guarantee issue all the time. So you can change someone's plan 365 days a year with no health questions. It's straight guarantee issue. If they have a plan F and they want a new one because the rate's gotten high, go write them a new one. Your commissions are going to be weak, and the rates are super high in those states because it's all community rated and guarantee issue. So in those states, what tends to prevail? In a lot of ways, Medicare Advantage. Washington is similar. You can guarantee issue on a Plan A switch. Missouri, and this needs to be updated because some of these rules have been expanded. Missouri offers guarantee issue on your policy anniversary date. So in the month that your policy is renewing, you can choose in Missouri, like, oh, I'm going to go shop this and I can get guarantee issue and flip. Birthday rules exist in different states like California, Idaho, Illinois, Nevada, and Oregon, which means every month of your birthday in California, as an example, you can change your Medicare supplement plan and shop it, no questions asked. You can shop it 365 days a year, but you got to get through underwriting. But in California, on the month of your birthday, you can do it with no underwriting. And not all states require under 65 Medicare supplements, right? Some people get Medicare at age 55 because of disability. But depending on the state they live in, doesn't mean a Medicare supplement's available to them. That is going to be a state-specific regulation. You'll want to look into your state to find out what plans, if any, are available to people under 65. The end. I do want to jump in. I'm going to go ahead and go over time, and we'll just make this a long one, and you guys can tune in as long as you want. It will be recorded, as it always is, and get pushed up. But I want to go ahead and move to this one. No, 101. I thought I had 201. No, it is the same one. I guess that is all I have. Sorry. I thought I had some more stuff on here. Give me a second, because I do have some more notes, because there's some questions in here I want to answer. I do have a few things. I knew there was some extra stuff in here. Selling Medigap plans. If they're new to Medicare, right? Because when I got in the business originally back in 04 and 05, 06, and I was selling Medicare supplements door to door and telemarketing and whatever, I didn't sell to T65s. I didn't want to talk to T65s at all. I had zero interest in talking to T65s. Why? Because I needed to educate them about Medicare. And I didn't want to. I didn't want to have a long conversation about, oh, let me teach you about Medicare. Here's what Part A covers. Here's what Part B covers. I didn't want to have to approach people 6 months, 9 months. I needed money today. I can't wait that long. So I sold to replacements, which I'm going to jump on here in a second. But if you're selling to people new to Medicare, you just have to understand that that is a longer sales process, because you might be talking to them 5, 6, 7, 9, or 10 months before they even turn 65. So it is a longer sales process because of that Medicare education. You will get 100% placement on your business because there's no underwriting, because they're going to be in their open enrollment period. So you get 100% placements, 100% placement on your business because of no underwriting, and you get full comp. You also have really good cross-marketing opportunities because there's other products these people are going to need. I wrote a Medicare supplement yesterday for a T65. I wrote 5 apps for this guy. I didn't just sell him a Medicare supplement. Medicare supplement plan, drug plan, granted, no money there, whatever. I wrote him a fat dental plan, a vision plan, and I wrote him a home health care plan. Easy peasy. So you get a much higher lifetime value on those T65 clients because there's more products that they need. Alternatively, selling to replacements is faster. That's a shorter sale process. You might even be able to one-call close your replacement business. These are people that already have a Medicare supplement plan. They probably had it for a few years, and they're just tired of seeing the rate increases go up. So they're like, hey, can you get me a Plan F that's cheaper? So you're going to sell on premium savings. It's a short sale because you don't need to educate them about all things Medicare. All you got to do is remind them, like, hey, I can change your Medicare supplement plan 365 days a year. We just got to get through some health questions. And if they can get through the health questions, boom, you can flip them. You're going to get a high, because the premiums are higher at those older ages, you're going to get a higher commission than selling at T65. And you get really good persistency on that business. Because think about it. You got a guy that's been on a Medicare supplement plan for, say, 8 years, right? He bought it. When he bought it, it was only $100. Now it's $250, $300. Not uncommon numbers, believe me. And he's still healthy enough to change. And then you can find him and bring him back down to $150. You can save him $50, $100, $150 a month. That dude's your new best friend because you just saved him a ton of money, and he's very appreciative. Plus, the odds that he'll ever get another, now it depends. Like, he might keep himself super healthy for a long time. I've got one client that takes really good care of herself, and she reshops her Medicare supplement plan with me about every 3 years. She knows the game. So every 3 years, she'll call me and be like, hey, let's reshop it again. And if I may only be able to save her $20, she'll still flip because she understands the game of what's going on there. Keep yourself healthy. You can change your meds up 365 days a year, right? So when you do flip them, you usually get really good persistency on that business. And in most states, Medicare supplement plans pay level commission for 6 years, pay 7 years in Texas. And then you have another trailer after that. Generally, all your carriers are going to pay you a 10-year comp. Some will pay you a minor trailer starting year 11 plus. Marketing and compliance. And this is one of the key factors when it comes to selling Medicare supplement plans. All of those marketing guidelines that you hear about every year, the scope of appointment form, I can't cold call people to sell Medicare Advantage plans or drug plans. I have to wait 48 hours after my scope. I have to record my calls. I can't cross-market any of these products with it. All of those rules apply only, listen closely, those rules apply only when you're selling a Medicare Advantage or a Part D drug plan. None of those rules apply to selling Medicare supplement plans. Therefore, you can cold call to sell Medigap plans, except Ohio. Ohio doesn't allow you to cold call anybody 65 or older for any reason whatsoever. All 49 other states, you can cold call and sell Medigap all day long. You can door knock with the intent to sell Medigap, again, except Ohio. And you can cross-sell anything with Medicare supplement. It doesn't matter. I wrote this dude yesterday. I didn't need a scope of appointment with him because he actually did his drug plan on his own. I just advised him and sent him off. So really only wrote him 4, to be honest. But I didn't need a scope of appointment. I didn't need a 48-hour cooling off. And I wrote him 4 products, piece of cake, right? You don't need any of that crap. There's no certifications to sell Medicare supplements. The only carrier that you would ever get appointed with that offers Medicare supplements and would require you to certify would be United Healthcare. And that's only because they're also a Medicare Advantage carrier and Medicare supplements are included in their package. You can get contracted with Humana. You'll get immediate access to their Medicare supplement. And then if you certify, you'll also get their Medicare Advantage plans. Any other carrier, like a Bankers Fidelity or whoever, there's no certifications. If you got a license, go fill out the contract, get approved, get an agent number, boom, bang, pow, you can start selling MedSup. So when you're building your MedSup portfolio, you do not need to worry about every Medigap product out there. You want to look for about 5 carriers to choose from. You need 1 or 2 flagships. You need United Healthcare generally. You need a Mutual of Omaha generally. You need a couple of big brands in your pocketbook or in your portfolio because people are going to ask for them by name and you want to be able to present them, right? And some people will, even though they probably have higher prices, some people will still demand them. I had a guy in West Texas who demanded Blue Cross. The Blue Cross plan I wrote him, and this was plan G because he couldn't even get a plan F, was like $231 a month. I could have gotten him a Humana plan G for like $105. I gave him 3 shots. And then I eventually just wrote him Blue Cross because he wouldn't listen to me. And he demanded Blue Cross. I'm like, hey, no problem. If you want to, You're the dummy, not me. Like, I'm trying to get you off the hook here. But you're like, all right, Blue Cross is a great carrier. That's who I want. Fine, I'll write it for you. So you need a big brand in your pocketbook just so you can have that product to reference when they ask about it. You also need a rate warrior. You need one of the lowest rates in your state, like a Banker's Fidelity, which is an extremely competitive product and also a very reputable product. So you need a solid rate warrior that's in there with some super strong rates. And you need one or two carriers that might have a little wiggle room in underwriting, like an Aetna Supplemental, as an example. Or again, back to United Healthcare, they have a little looser underwriting, right? And then you would just add or replace carriers as needed, right? Because that rate warrior might only last 5 years before you need to rotate it with something else that's cheaper, right? Or a new product might come in that has better wiggle room than your previous ones did. Or maybe the rates, there's things change. It's an evolving market. But you don't need every carrier. You need about 5 good products to run with. And then every once in a while, you will rotate some of those in and out. So check out quoting. That's the end of this one. Quoting is pretty simple. I'll do that with you guys another day, and we'll go over market analytics and how you would actually choose them. Real quick, I do want to answer another question that was in the group. Moving from Medicare Advantage to Medigap plans, when and how? That's the part I'm stuck on. You can do that during AEP or OEP or an SEP, but you can't do it any other time, right? The only time you can leave your Medicare Advantage plan is during AEP or OEP, or if you get some weird SEP, right? So during AEP, you can bail on your Medicare Advantage plan, pass underwriting for a Medicare supplement plan, and it would start January 1. During OEP, which we're in right now, if you have a Medicare Advantage plan and you want to exit it, you can exit it, go back to original Medicare, and then hopefully pass underwriting for a Medicare supplement plan. Pretty simple. So that's an easy one. Other than that, you can write Medicare supplements 365 days a year. I am overtime. I'm also late for a meeting. Sorry, Atalabi, but I'm coming. And I will catch up with you guys next week. We'll jump into some more of this, and I'm going to go over market analytics on Medicare supplement products, quoting. We'll do some sales language and some popular bundling. How's that sound? Look out for next Tuesday. We'll see you then.